average Kentucky primary care practice, it's likely that 1 in 8 patients over the age of 18 have diabetes and 1 in 3 have pre-diabetes. Meanwhile, our state is spending $4.8 billion each year treating a disease that could often be prevented or properly managed through diet, exercise, and adherence to prescription medication guidelines. Patients need to understand their role in the prevention and management of diabetes. This is where we need to do a better job linking the clinic to the community. I realize that as providers on the front lines of our healthcare system, you simply do not have the time to provide adequate education for each of your patients. However, you can ensure that they are provided the opportunity to receive this critical training. Public health can help you. Across the state, there are nationally recognized and accredited diabetes prevention programs and diabetes self-management and support education programs that are available through a variety of organizations, including your local health departments. These programs provide state-of-the-art education and disease management skills geared toward diabetes prevention and diabetes management. The only problem is that people aren't taking advantage of these courses and attendance remains low for both programs. That's where we need you to intervene. Intervene on behalf of your patients to make sure that they are being screened for diabetes and pre-diabetes and are referred to these services as appropriate. Pre-diabetes is treatable, but 9 out of 10 people with the disease don't know they have it. As you know, left untreated, patients with pre-diabetes are at risk for developing type 2 diabetes, heart disease, and stroke. Diabetes prevention programs are one of the most effective ways to prevent or delay type 2 diabetes in high-risk patients, cutting the risk of developing diabetes in half. Meanwhile, DSME help patients make better self-management decisions with healthy eating, taking medication, being healthy, monitoring, healthy coping, problem solving, and reducing risk, as well as lowering A1C, blood pressure, and hospitalizations. Unfortunately, only about 50% of people with diabetes report ever having received formal diabetes self-management education. The need for DSME is ongoing. According to the American Diabetes Association Standards of Care, there are 4 critical times to refer for DSME: at diagnosis, during an annual assessment, when new complicating factors influence self-management, and when transitions in care occur. If you aren't sure where courses are offered, we encourage you to visit the Kentucky Diabetes Resource Directory online. You can also visit the Kentucky Diabetes Network website, which is full of free resources for physicians to use in your offices to better reach patients and make sure they are getting the diabetes information they need. Think of it this way: if there were pills that you could prescribe that would cut the risk of developing type 2 diabetes in half for your patients at high risk, lower A1C with a low risk of hypoglycemia, and not cause weight gain or other negative side effects, and was inexpensive, would you prescribe them? Don't forget that improving outcomes for your patients with diabetes also improves clinical quality measures and can help you achieve pay for performance and quality improvement goals. Thank you for your time, and I hope you will consider referring more of your patients to these programs. They can truly make a difference in diabetes prevention and care.